on using a low-dose, high-frequency approach to address PPH. Sherry will present some of the early work and thinking, and Tiba will present how we've used that work in Tanzania. So Sherry is the director of the Global Secretariat for Helping Mothers Survive, and Tiba is the technical director for a large and exciting project in Tanzania called Boresha Afya. So Sherry and Tiba, over to the two of you.
Thanks so much for that introduction, Chantal, and thank you everyone for joining us. We are here to talk to you about a low-dose, high-frequency approach that can improve team and provider performance for postpartum hemorrhage. Many of you may have heard of that term, so we're going to tell you what that means to us. We didn't coin that term, but we definitely have co-opted it and used it. Okay, so we are going to talk today first about the evidence for in-service training and capacity building using a low-dose, high-frequency approach more broadly, but then we're going to talk specifically about evidence for in-service training and capacity building specifically for prevention, detection, and management of postpartum hemorrhage using the low-dose, high-frequency approach through the Helping Mothers Survive training program. Then we're going to give you a real-world implementation project through USAID Boresha Afya in Tanzania that has been improving provider and team competencies for postpartum hemorrhage. So taking a step back, our evidence for in-service training that we've been reading in the literature for the last several years now is suggesting that training the way we have traditionally been doing it, even when coupled with supervision, has not meaningfully improved quality of care. In this study with Hannah Leslie and her co-authors in 7 sub-Saharan African countries, this traditional approach, even when coupled with supervision, did not improve care in any meaningful way for pregnant women or sick children. And that traditional approach tends to be these workshop-based trainings where we pull people out of their facilities. And then in India, Varghese did a study using a more localized approach and using hands-on training, but this also did not really meaningfully change outcomes. At the same time, Jopaigo was doing a deep dive into the literature, and what we were finding is that the most effective in-service techniques for training and to change provider performance and behaviors was not reflected in the traditional approaches we were using. So what this integrative review of the literature showed is that technique, so the skills and drills that India was using, coupled with location, which the Varghese study also used, were very important, but also the dose and frequency of the exposure to the learners or participants to the skill building, the competency building, and even the knowledge mattered a lot. So Jopaigo took this, what we learned in this literature review, and we applied the term low dose, high frequency because we really felt at the beginning that this was a very important component. But for us, low dose, high frequency means much more. So it is facility based, it's hands-on, giving manageable amounts. So that would be the dose, the learning, whether it's knowledge-based, decision-making, or skills building. And then at appropriate intervals. We all know that the more we practice something, little bits of practice over time help us perfect a skill. And then deliver this to the entire team. And that should be followed by short and repeated skills practice, if it's a skill that's involved, or quality improvement activities as relates to the clinical subject. And ideally, this is all embedded in quality improvement frameworks within a particular program and facility. So when this review of the literature was in process, we were also developing Helping Mothers Survive, the first module, Bleeding After Birth. And we were developing it. Jopaigo led the clinical development of it and the content development. But it was, we brought in our global partners, FIGO, ICM, UNFPA, et cetera, to give input and actually to be part of our field testing of this. Once we created this low dose module, we wanted to test the health outcomes and the impact and the change in provider performance. So in a large study, 125 hospitals and health centers in relatively remote areas of Uganda, we did this on-site team training in a cluster randomized controlled trial in these 12 districts shown here. So just briefly what we did for the data collection, because I'm going to give you some outcome measures, is that before we did the training, after the intervention was complete, and then 6 to 9 months later is when we went in and collected very specific data, direct clinical observation. We got data from registers and the HMIS. All 3 study groups received the same training and were asked to do the same things. The difference is that in 2 of the groups, there was a practice coordinator that was someone who was already on site, who was supposed to help her team after training day do these small deliberate practice exercises to keep their skills sharp. And in one of those 2 study arms, there was some phone calls back and forth between the district trainer and the coordinators just to remind them to conduct their practice sessions. So what this looked like is a single day training. You can see the district trainer comes to the facility, provides it to all in the facility, and then the trainer prepared 2 practice coordinators who were already there on site and were invited to be involved in leading these weekly practice sessions and drills and quality improvement exercises. In this particular case, there were 8 weekly 10 to 15 minute exercise that were done. This was at 125 hospitals, as I said, with greater than 700 providers and more than 70,000 deliveries. And we repeated this with newborn asphyxia training, or HBB, recognizing that care of the woman and care of the newborn happen at the same time. So we wanted to capture both. So to give the results, of course, we collected on the newborn as well, but relevant to this particular meeting, we had a reduction of postpartum hemorrhage of 17% and of retained placenta by 47%. So I'm going to stop there, and Tiba, over to you.
Thank you, Sherry. My name is Tiba, and I'm here to present to you what the Breakout Tanzania office is seeing in the field. We are using low dose high frequency in USAID Boresha Afya Lake and Western Zone project in Tanzania. This is both mainland and Zanzibar. The project is 5-year. We are now in our 4th year, and we are supporting around 1,800 health facilities in the 7 regions. These 2 zones which we are supporting are actually characterized by high maternal mortality ratio, as well as a newborn mortality rate and the gender-based violence, as well as malaria incidences. We are supporting the government of Tanzania to be able to increase access to quality, comprehensive services with the focus to maternal, newborn, child, adolescent, reproductive health outcomes. A low dose high frequency approach is actually practiced across the technical areas that I've just mentioned, and more so postpartum hemorrhage, which actually is causing about 30% of maternal mortality in Tanzania.
Did we lose Tiba?
Tiba, you're on mute, if you don't mind taking yourself off mute. Perfect.
Yeah, I'm saying next, please, sorry. Yeah, a low dose high frequency approach for postpartum hemorrhage in Tanzania is taken as a facility-based learning activity, combining the structured skills practice as well as peer assessment and feedback. We have mentors who actually are the maternal newborn health proficient providers, and who have accepted the role of becoming mentors. They receive a 5-day training using national package, and it is followed by 1.5 days training of breathing after birth complete module, of which they also receive orientation on how to conduct a similar training, starting with their own sites. And then after they've done at their own sites, successfully. They are also used as resources to train others on job. These mentors at each facility where they go, they leave behind 2 peer practice coordinators to be able to oversee the weekly practices among other roles of building capacity of peers and ensuring how the sessions are planned, are followed, are monitored, are documented, and linked to other quality improvement measures. During these particular sessions, at least each provider gets time to practice a specific skill, including using models and use of standard checklists for both learning, but also the modified ones for assessment. This is observed skills clinical examination. And then we are practicing use of learning corners to provide some space whenever there are quiet periods so that the mentees, the providers, can achieve more skills. Next, please. Thank you. In supporting low dose high frequency, as I already said, you are using learning corners, which actually take different shapes according to the size of the health facility. In some facilities, they are just a space, as you can see on the picture, but with organized requirements. Somewhere they put the requirements in the cupboard, provided they can move the requirements and put it as a space to practice at a quiet moment when clients are not that much active. And specifically, there are learning and references, documents, as well as equipment. For postpartum hemorrhage control, as well as identification and detection, we have instructional materials, including the action plan, as well as the guides. We also have infection prevention requirements for the practices that are the imitated actuals. So infection prevention measures like hand washing are also practiced, and the other personal protective equipment are put in place. In this particular sense, with PPH, there could also be a need for sustaining a newborn. We have sustain requirements. The simulators, as already said, and importantly, we have logbook where a practice coordinator is ensuring the performance of which mentees who is getting to practice get documented for easy follow-up and monitoring. Importantly, the assessment scores so that the peer coordinator is all the time conversant as of where mentees started in terms of skill and where one is, so that those who are ready, they are certified to go into another stage. Next, please. So with these interventions of capacity building being enhanced by low dose high frequency, we have seen that ultrasonic coverage since the year 2014, the coverage picked up, starting with maternity survival program, which was also led by JPIGO, and now with USAID British Afia, starting July to December 2016, we are seeing sort of universal coverage of uterotonics, which actually is to prevent postpartum hemorrhage with the administration of uterotonic at least within 1 minute after birth of the baby. Next, please. We are also seeing that the PPH incidence and case of fatality rate at those sites, there are some positive improvement. We started with 38 hospitals, and now we have 52 hospitals. But the practice cuts across also in the lower level facilities. So while PPH incidence has remained below 1% across the sites, the additional of one region, as I already said, this is October-December 2017, caused an increase in postpartum hemorrhage case fatality rate for the project overall. However, we are seeing some positive outcomes, whereby at least the incidence is remaining not that high. At the same time, whenever there is an occurrence, the case fatality rate is also not going upwards. At least the providers are now embracing the measures to be able to prevent, as we saw almost overall the coverage of prenatal tonic use immediately after the baby is born. And then the capacity to detect whenever there is PPH, although it has some difficulties, but there is some improvement in detection. And then in terms of management, also service providers are coming up, being able to reduce the case fatality rate. Thank you very much. The next one, please. Yeah, our appreciation. This is now a project to the Tanzania government for allowing us to do this practice, and now we are generalizing, influencing the policies and the practices, and importantly, the USAID being the donor to be able to fund and support us in implementing, in assisting us to implement, to be able to address postpartum hemorrhage in the country. Thank you, everyone. Over to you, Sherry.
Tiva and Sherry, thank you so much for that really interesting presentation. It's a great example of where we've used the evidence, tested it, and expanded it in a new project. So I want to start off the questions. So just a nudge to our attendees, feel free to ask a question in the question and answer function. But just to start off that process, we've got an interesting question from Farzana. And Sherry, the first part of the question is really directed at you. If we think about a training cascade, so we first trained that group of district trainers, and then those trainers then reached out to the facilities. Could you walk us through kind of what those numbers looked like? Kind of how did it happen? Because I can tell Farzana is thinking of it from a programming point of view. You know, how do I make this work? So if you can kind of help us to work through what that looked like, and really kind of what the actual physical practice in a facility, you know, what did it take? Was it 5 minutes, half an hour? What did that really look like? And in practice, what did those coordinators at the facility level do?
Sure.
How effective were they? If you can kind of just help us see it.
Okay, yeah, so those are great questions. So, you know, I think we have learned that the longer the cascade and the more levels, it's like playing telephone. I guess that's an Anglophone potentially analogy, but the quality falls off. So if I tell you something and you tell somebody and you tell somebody. So with our approach, we try to make the cascade as short as possible. So for instance, in Uganda, we had a national level training, but we brought together two district trainers from each of the districts where we were implementing who were already employed there. They were employees of the government. Training was some function. Usually they were at the referral hospital. They were clinically active midwives, all of our district trainers. And so we did bring them together because they were from far away from each other. So we brought them centrally, we trained them, and then we returned them to their districts, but we went with them. So they were mentored. In fact, Tiba was part of that study with us, and she went out to the field with, I believe it was probably 2 of the district trainers or maybe 4, and she facilitated with them and mentored them in their first training. And that we feel really had a big boost for the quality of the training. And then we let them roll out to the district, the facilities in their district. And so I think the range was between 7 and 17 facilities per district. So the Ugandan districts had been carved up, so they were relatively smaller. And the role of the 2 district trainers was to go around either individually or together, depending on the size of the facility, because we want the ratio to be relatively small. So we used a ratio of 6 trainees or learners, 6 providers to 1 facilitator, and that would give hands-on practice time for everybody. So they would have the 1-day training, and then the district trainers would stay behind for the next half day, and they would orient, and that was one of the questions, these practice coordinators. So the practice coordinators received the training as their colleagues did, but then they were invited to participate, to be the ones to lead these practice sessions. So currently, Bleeding After Birth has been expanded to be Bleeding After Birth Complete, which has the advanced care functions, which are being used in Afghanistan. And Afghanistan actually was the reason that we fleshed this module out further. And so the practice sessions currently are anywhere between 10 minutes and up to 30 minutes, depending if you're practicing cervical laceration repair, for example, or uterine balloon tamponade. So I hope that in a nutshell gives you what you're looking for. Tiba, do you have anything to add about the programming perspective? Because you use a slightly different approach in Breakout, Afia.
Yeah, not very much different, but actually it does not take long, so long as all resources are in place and the advocacy has been effective. Once there are mentors, the mentors would be assigned to a number of facilities to build capacity on. And when the peer coordinators are left behind, actually the duration and the number of low-dose high-frequency practices differ facility to facility. The smaller facilities tend to have fewer providers, so they will finish the sessions faster. It is like a straightforward, structured system, provided resources are available. Yeah, this is what I can say.
Thanks, Tiba and Sherry. I think those are such great answers, kind of help it feel more, how would we program it? I think another fascinating question, and that I will make our last question, if you can believe we've already finished half an hour, is really about power and hierarchy. And this is a common challenge that many countries and situations face. How did you really feel that this different approach to training, was it able to address that? Was it able to kind of be effective despite those hierarchical kind of more traditional power structures within facility teams and facility management? Any thoughts or insights from your practice or your own thinking around this and this different approach to training?
So I would like to turn that one over to Tiba, but just to say in different countries, we have greater or lesser challenges. And so I know, Chantel, you actually have some experience with that too. It wasn't necessarily about postpartum hemorrhage, but they are real. So Tiba, what about the Tanzania example?
Yeah, actually the approach tends to empower the providers as well as peer coordinators. So they open up and they specify their needs all the time, which actually enhance, they become more confident and they know what they want, they know what to document, they know, that kind of thing, which clients benefits. So that's the reflection I can tell now. By the fact that they are working together, they are feeding each other, they know what is missing, they are communicating, it becomes very useful.
And I feel like role modeling when you're going in to provide that, like at the national level, when in Uganda,